Hello, everyone. Welcome to this YouTube Hangout with evidence-based mental health from the BMJ. I'm Michael Ostacher at Stanford University. I'd like to welcome you today to our terrific Hangout. We are discussing today a new paper in our journal, Selecting a Risk Assessment Tool to Use in Practice, a 10-point guide, and we're joined by both authors of this paper and by some guests. Seena Fazel is a professor of forensic psychiatry at the University of Oxford and a Wellcome Trust Senior Fellow in clinical science. Currently works clinically in Oxfordshire Prison and previously in forensic psychiatric hospitals. His research focuses on risk factors and more recently improving risk assessment for adverse outcomes in psychiatric patients and prisoners, and also by Achim, who's a senior research fellow at St. Andrews Healthcare and an honorary research associate at the Department of Psychiatry in Oxford. He works on translational research projects in secure mental health settings and continues to advise on risk assessment, research, and implementation. And we're delighted to be joined as a discussant by Dr. Faye Professor Faye Taxman, who's at George Mason University, where she's university professor in criminology, law, and society, and is the director for the Center of Advancing Correctional Excellence. She's recently edited a book published by Routledge on risk and needs assessment, pressing issues in this area that have been sponsored by the American Society of Criminology. I want to let everyone know that we have if you are able to watch us now, you've obviously found us on YouTube or gotten our new link. Please follow us on Twitter through our Twitter account, EB Mental Health. And also, if you have comments, please send comments on Twitter using the hashtag EBMHChat. EBMHCHAT, and we'll respond to your questions during our discussion. We're also joined by our editor-in-chief, Andrea Cipriani, who is associate professor of psychiatry, also at the University of Oxford in the Department of Psychiatry there. Seena, why don't you get us started on your paper, and we can move forward.
Thank you very much. Well, I've got a few slides, so I think I'll start off by just talking through the slides. So I'm just going to set up the slideshow. So what I'll start off is just saying a little bit about why bother with risk assessment, a little bit about the evidence around risk factors, and something about current approaches and their problems. And then what I'll do is I'll hand over to Achim, who'll speak specifically about our paper, which looks at how you can select the best tool for your purposes if you work clinically or in criminal justice. So why bother? Well, the main reason to bother, I think, is the absolute rates of crime and other adverse outcomes, including suicide and suicidal attempts, are still quite high in psychiatry. So here's some information by diagnostic group. In schizophrenia, you can see that for men and women it's approaching about 8%. In men it's actually more than 8% within 5 years of diagnosis. Suicide rates obviously much lower, but still they're above 1% for bipolar disorder and schizophrenia within 5 years. And they're two considered rare outcomes. I mean, they are relatively rare, even if you look at 5-year periods of time. If you look at schizophrenia specifically, and you look at 1, 2, and 5-year outcomes, if you look at the top bar chart here, you can see in men.
Yeah. I think we still only see the first slide, so if you can advance us.
Oh, okay. Can you see any more slides now or not?
No.
No, just the first slide. Okay. Then I might just talk to
Oh, there we go.
Now it's working.
There we go.
There you go.
There you moved it.
So that was supposed to be my second slide, which is looking at absolute rates of violent crime and suicide within 5 years of diagnosis for schizophrenia, bipolar disorder, and depression, and that's violence and that's suicide. And then this is a slide looking at schizophrenia specifically, and what I was highlighting was in men, you have absolute rates of more than 10% for violent crime within 5 years. And I think in medicine, anything with absolute rates of more than 10% is of concern and needs good systems in place for risk assessment and risk management. You can also look at other outcomes. So this is any violence, not just violent crime. And this is within a year, and these are annualized rates for different patient populations. So if you look at first episode psychosis, this is a meta-analysis, and it's up to a third of patients report some perpetration of violence in over a year period. And that's obviously very different in people who are settled and well treated. And so people have written about this, and I think it's important to acknowledge the fact that we do have high absolute rates for some of these adverse outcomes, and the question is what we can do about it. I mean, one of the good things is that, one of the positive things is that some of the risk factors, and this is a review we did of over 100 studies in psychosis, and some of the risk factors are modifiable. So, how can we link the assessment of patients, particularly high-risk patients, to actually interventions that might address these modifiable factors, such as substance misuse and such as some symptoms, and specifically positive symptoms, increase your odds by about 40%. So what people have developed over time is as part of the approach has taken is to come up with risk assessment, and that means lots of different things. One of the things it means is a sort of unguided clinical assessment that a clinician would make, and then what's been developed over the last 10-20 years is to try and inform that using information on risk factors, and you can get just the risk factors to give you a probabilistic score, what's called an actuarial assessment. Or you can have risk factors, and then clinical judgment is then made on the basis of looking through risk factors, and then you can, through clinical judgment, decide if someone is low, medium, or high. And that's how things have developed over time. The problem is actually, and here are three of the most common risk factors, the instruments rather, that are used in psychiatry. This is the psychopathy checklist, this is the VRAG, and this is the HCR20, and these are the three most commonly used. Is in a paper, they looked at which of the factors in them, and they have 20 factors, which of these factors are independently associated with the outcome of violence, and actually very few of them. And so there's a little bit of wastage in these instruments, and that they often have collinear factors, or they include factors which don't have a lot of evidence behind them. Another problem a little bit in the field is that, like with a lot of science and medicine, is that we have a lot of potential biases that creep into literature, so you only tend to get research published that seems to have higher, show that these tools perform quite well. And when independent groups do the research, the performance of these tools is less good. And another problem is that high risk, if one of these tools tells you somebody's high risk, this is a review we did, and we found that what that actually means over a year, if you follow those people up, can range anywhere between, for the HCR, 25 and 100%. So actually the language that you use around these tools may not be helpful. They may not communicate the same things to the same people, which is what you want if you want to be able to use these tools to communicate where someone is on in terms of risk. You want to be able to know what actually high really means, and the evidence is that high can mean really very, very different things. And finally, I mean, the ultimate test of these approaches is whether they improve outcomes. And in outpatients, there's only ever been one RCT that we're able to find, and that RCT didn't find any improvement in outcomes when they added a risk assessment to what was currently being done. So basically, I mean, there are some problems. A lot of these tools are quite costly. They take a lot of time to use. They're not transparent, so we're not quite sure how the evidence feeds into the tools. You know, what coefficients, how the tools are weighted, and if they're not weighted, what each risk factor, how it contributes to the tool. It seems to be publication bias, and I think some of the risk factors that are in that reflect the current evidence base. There's a bit of a guru-like system, training, and the cutoffs appear not to be consistently used. So one of the things we've been interested in is how to do things. And there are lean and scalable and evidence-based approaches. And the rest of
Faye, if you're able to mute it, that would be.
I'm sorry, what do you want?
If you're able to mute at the top of your screen, we're doing an echo.
Oh, okay. Oh, okay.
There's a slight echo.
Is that better?
So a good example is the framing and risk score, the Q risk, which is used in the UK. And the key thing about them is that they are based on good, strong evidence base, linked obviously to interventions that make a difference as well. But at least you have to start somewhere, and you have to start with a good risk assessment, and then you can start thinking about how to link it to better interventions. So at this point, I'm going to hand over to Achim. And ask him really just to talk through our thinking around what are the approaches one can use to select a risk assessment tool.
Great. Let me just bring up a couple of the slides. All right. Can you see the slides?
Yes.
There we go. Perfect. Thank you. Right. So we developed this list of 10 items that we think are crucial when selecting a risk assessment tool to use in practice. First, I'll talk about what to look for in a validation study, which is the optimum way to approach it. And then I'll go through 5 items of the derivation study. So if there are no validation studies available, how do we select candidate tools that could be used in practice? Looking at validation studies, the first important bit is it a true external validation? The only true measure of performance of a tool is how well it does in a new sample.
Yes.
The sample it was developed in, there are different ways of adjusting for it to make it fit perfectly with that sample. So that is not a real reflection of how well it does. The important thing is moving it to an external validation and see how well it does there. The second question is, in the validation study, is the population comparable to the one you're interested in? For example, if you're interested in predicting risk in prisoners, but the tool was developed in a forensic sample or in a different gender to the one you're looking at, then the tool is unlikely to work as well in that population. Next, it's crucial that there is a protocol so that it follows the same rules that the original study developed, so it doesn't try to create a new tool. Otherwise, we are no longer validating a tool, we are creating a new tool if it's adapted to the new sample. And we also have to make sure that we have a sufficiently large sample size to actually have statistically interesting results and worthwhile results. Finally, generalizability is important, which means that if, for example, you are using collected data where patients had to consent, for example, and a lot of them do not consent, then the tool may not work as well, because the sorts of people who don't consent may well be different to the sorts of people who consent, which may affect the generalizability of the validation study. Next, it's important what a tool actually reports. Just providing an AUC is not enough, because that gives you an overall measure of how well it discriminates between those who have the outcome and those who don't. It's also important to have discrimination statistics at the cutoff points. So if you're saying everyone above 20% is considered high risk, then it's important to have sensitivity, specificity, positive predictive value, negative predictive value, and so on at that cutoff. And it's also important to look at a second type of performance measure, which is calibration. Discrimination is how well it discriminates between a person who has the outcome and a person who doesn't. Calibration is, does the predicted risk match the actual risk? So if a certain type of person, you predict on average 20% of them will offend, but 30% of them offend, then this is a badly calibrated tool. Next, the question is it actually usable? There are tools out there that use large amounts of data through machine learning and collect thousands of variables and give you a tool that might perform relatively well in theory, but in practice, you can't use that tool elsewhere because you won't have the same data available. It's very complicated to fill in, and it's not very acceptable to the people who have to complete it because it's often a black box, as they say, that you enter the data, it gives you a result, but you don't really know how you got there. Right, so this is the 5 questions to answer for validation studies. However, if there are no validation studies available, or they're not exactly the population we're interested in, I will now move on to the derivation studies and look at the key questions that we should answer there. First, it has to have a protocol. The analyses have to be pre-specified, the sample has to be pre-specified. Otherwise, what we started off with may be very different to what we end up with. So that's why I said the important thing is how well it does in external validation, because in internal validation, particularly without a protocol, you can keep changing variables a little bit until it tells you basically what you wanted to tell you, which is not very accurate once you try to test it elsewhere. The next question is, how were variables selected? Some tools consider hundreds of variables, thousands of variables, and include the ones that are significant. The problem with that is there is not enough statistical power to test that. The general rule is that for each variable you want to test, to decide whether or not to include it, you should have 10 outcomes. So if, for example, in prisoners, you want to predict the risk of reoffending, if you want to test 20 variables, you have to have at least 200 people reoffending in the time period that you're looking at. Next, how were the variables weighted? A lot of the tools out there either use a 0, 1, and 2, like the ACR20, or a Likert scale, where people are asked to rate from 1 to 5 how much someone has a particular risk factor. The problem with that is, it's difficult to complete because one person might say 4 out of 5, another person may say 3 out of 5. The second issue is it assumes that all these variables are equally important. If you add a score of 4 from one variable to the score of another variable, which is also 4, that assumes that both are equally important. But if you have, say, income and previous offending, obviously previous offending is a much better predictor of reoffending than low income would be. The other problem is if you include them all at the same time, some of the variables might be important on their own, but once you adjust for all the other ones, that particular variable might not add anything extra. So it's important just to look at the relative importance when all the other ones are included and give the appropriate weighting, ideally through multivariate analysis. Next, how were all the other parameters selected? By that I mean, how was the sample selected? How was the outcome selected? Is it, for example, violent recidivism, general recidivism? Is it police collected crime? Is it self-reported? All these things to be pre-specified. Otherwise, you run into the problem of multiple testing, where you will say, actually, I wasn't interested in 3 months outcome, I was interested in 6 months outcome. The analogy we give in the paper is you are betting on a horse and you say will win the next race, and when you realize it lost, you say, no, actually I meant the next race. And you can keep changing that until you basically find a horse that wins and you say, there you go, my horse does really well. But in practice, that wouldn't really then work going forwards. And finally, it should have some form of internal validation, ideally. Internal validation can only tell you so much, so external validation will be necessary. But internal validation is a good first step. It's basically, if you use something like bootstrapping, it reselects randomly people from that sample to create. It's basically assuming that the sample isn't exactly the way it is, but has slight variation in it. How well does the tool perform? And that way, it gives sort of an overall level of, it gives you a level of uncertainty around the performance of your tool, which will help you going forwards when you want to validate it. There we go. So these are the 10 items that we think people should think about before choosing a risk assessment tool.
That's terrific. Does anybody want, do you think it's worth discussing at this point some of the things that you've both brought up? And Faye, I think, come on.
I'd be happy to discuss some. Oops,
Wait.
sorry.
Wait.
Sorry. Oh, darn. I seem to have lost you guys.
No, you're here. No, you're here.
Oh, okay. I'd be happy to discuss the paper and the presentations that our esteemed colleagues, Seena and Achim, presented. I first want to really, I think this is a very critical paper for our field right now because, you know, there is, I can talk about in the United States, there is a proliferation of risk and needs assessment tools, and a lot of organizations at all various points in the justice system are adopting these tools. And what we seem to have now is users at the front line of justice, like probation officers and case managers and folks like that, who basically, you know, are suspect about the tools. And therefore, we're losing the credibility. And I think the issues that are raised in this paper give user organizations an important way of being able to ask the question, you know, are they getting out of their tool what they actually intended? And to review the methodology. I think another critical piece that is really important here is that you've given people almost a checklist that they should be able to ask the developers of their tools how they're actually doing and how they've done their research on this particular tool. And therefore, that adds, gives practitioners the list of things that they should really be talking about with their agency. So I had a question though that I wanted to raise. When I was trained in developing risk and needs assessment tools, I was trained off of the notion of having a construction sample and a validation sample, where you took your, your sample and you cut it in half. You randomly assign people to one or two groups, and then you use that as a validation sample off of the same sort of data set. But I got a sense from this paper that that actually Seena and Achim are thinking of it, that there is a need to get a new set of data, and I wanted to kind of get some sense if that's what they're thinking is a better validation than to take it from an original data set.
Yeah, Faye, it may be helpful for you.
Okay, sorry.
No worries. Okay, so Seena, Achim, I think this is a really important question that Faye's brought up about this. I think ideally, I think what you were saying is that there should be a validation in a completely new sample. Is that correct? Rather than cutting an initial sample into a construction sample and a validation sample.
Yeah, that's right. So the problem with cutting a sample into two randomly is that the risk factors will be randomly allocated to both samples. So the tool will perform quite well because essentially you're almost recreating a very similar sample. So it's not really a true external validation. It's and I think people in the field now think that's the wrong way to validate a sample. You shouldn't randomly cut up or break up a sample. You should, in some non-random way, do it. So what we did in our papers is we did a geographical separation. So we developed a tool in half of Sweden, and we validated it in another half of Sweden. And it was intentionally, the idea being intentionally that the other half of Sweden is that the risk factors don't automatically fall exactly back into the same place as they would in the other half of the sample. But one step better is using a completely external sample.
Yes.
Because that really tests, in the field they call it shrinkage, how much the performance of the tool shrinks. And the things that Achim was presenting, they're really ways of guarding against shrinkage. So if you have a protocol and you've decided ahead of time what your risk factors will be, it's pre-specify how they're categorized, pre-specify your outcomes, and then you have a adequately powered development sample, then that will mitigate against shrinkage. Because what you tend to see is a lot of the tools that have been developed, they shrink quite substantially. So they look pretty good in the original samples, and then you do a field study, and they perform quite poorly in the field study. And that's partly because of these problems, that the tool in a way has been the performance has been sort of artificially inflated because people have done, some multiple testing and they haven't used the best methods. And to be honest, a lot of the tools are very out of date. So they draw on literature which now is a bit dated. They don't include new risk factors that we have information about. And I think it's always very disappointing to see that, like Faye was saying, that these are being used in important settings, and yet they are sometimes the evidence base behind them is quite poor. And we cite a couple in our paper of tools where there isn't a lot of information. How they've been used and how they've been derived is not very transparent. In both cases, there isn't much even peer-reviewed literature in support, and yet they're being widely used.
Right.
So it's a bit of a problem. I mean, that people talk about evidence-based policy, and here's an area which could do for more evidence-based policy.
Well, I think that it sounds like in order for the evidence to have strength so that it can be applied in actual practice, it should be as well validated as possible. And doing it within a single sample, even if you've cut it up, doesn't really help you. You really want to know whether or not, when you apply it in practice to someone who doesn't come from your original sample, whether or not it has predictive value. I think that's important. And I think that goes back to what Achim was saying about making sure that when you're doing a risk prediction tool, that you're using the tool in the population that you've defined, which those both things need to be true, I think. Is that, am I understanding things correctly?
Yeah, that's right. So just to quickly summarize, the issue with cutting the sample in half randomly is, so we're all familiar with randomized controlled trials. The beauty of them is both sides will be the same statistically. So both sides are identical, but that's not what we want in validation sample. There, If you split it randomly, it's basically like doing bad bootstrapping. Bootstrapping does exactly the same thing, but hundreds of times, creating new samples.
Right.
So this is just a very basic internal validation if you split it halfway, randomly. If, however, you split it geographically, then you are not creating identical samples, you're creating comparable samples. And there's a big difference between the two, because one is you have the same thing, and one is with slight variation, how well does it do now? So I think if you split it geographically, like we have done in a number of risk tools, that is basically a true external validation. It's then still important to see how it works in practice, because obviously the data you collect might not be exactly the same as the data that's used in practice. But the random split, I think, should be avoided if possible.
Right. Faye, I think you can unmute if you'd like to make a comment about this.
Oh, thank you. Am I unmuted? Oh.
Yes. Go ahead. Oh, you muted yourself again. You were unmuted for a moment. Very good. Perfect. No. No, a single click. Not a single click.
Okay, sorry.
There.
So I'm wondering if the issue about cutting the sample in half has to do with the size, though. In our experience, where we get large data sets, 30 to 50,000 records, and then, we do a lot of, what was talked about in terms of discriminatory analysis and calibration of the issue. We tend to do that both on construction and validation samples. And I'm just wondering if in people's experiences, when they're talking about doing validation, they're thinking about much smaller samples, like 200 to 300, as compared to using large administrative databases.
With the random split,
Yeah, if you could go and mute while we go on mute, that would be great.
With the random split, the larger the sample size, the more problematic it gets. Because if you have a huge sample, then they will definitely be identical. Same with a randomized controlled trial. The larger the sample, the more similar the two sides will be. If you have a very small sample, then it's closer to an external validation if you have a huge sample. So in a way, the larger the sample doesn't make the validation any better. It still becomes a bad version of bootstrapping.
Seena, do you have a comment? You'll have to unmute.
No, I mean, I think statistical power issues are important, and they need to be carefully considered. I mean, we make some comments in our paper about what we think are rules of thumb about sample sizes, and they're based on statisticians modeling all this and research done in statistics to look at prognostic models and what constitutes statistical power. I mean, it's a relatively new field still, my understanding is, but there are some rules of thumb. And but with the administrative databases, I mean, it sounds to me like the power should exist, and it's really just a question of constructing the right sort of validation sample. I mean, one of the interesting things in North America, I mean, we noticed this when we had a quick look at the literature, was that almost each state creates their own risk assessment. I mean, Faye will know much more about this than I will, and it's sort of interesting because they all sort of slightly reinvent the wheel in slightly different ways. And and the little bit of a risk with it is that a lot of the approach is taken are not very transparent because they're developed in-house by correction services, or
Right.
sometimes they actually farm it out to an agent, a consulting firm, and the consulting firm doesn't share the background in data because they want to keep hold of it for various reasons. So So you have this sort of particular, I think, it sort of highlights the problem that you have internationally, almost within one country, where it accentuates. You can see the issues being played out between different states, where two states neighboring each other will have different risk tools, both of which have been developed in very different ways, and both of which, on the face of it, look like they have some limitations.
Yeah, and I think what you're pointing at is that these tools have a practical, important impact on people's lives. Isn't that correct? So
that's very right. Yeah, I mean, so they really are important because they, they're not the final decision making. Again, Faye can comment to this more than I will, but they help people make decisions, and they help, in some cases, sentencing policy. In some cases, when people go on parole, how intensive the parole should be. I mean, one of the things that we tried to argue in the tool we created was that, that if you are going to link it to an intervention, the intervention should be non-harmful. So, for instance, in released prisoners, it could be to give something additional, such as extra support or extra drug and alcohol treatment for high-risk prisoners, because the performance of the tools has to be carefully thought through about whether they're sufficiently good that you can do harmful things to people. So what we've argued is there should be, currently I think the evidence would suggest non-harmful interventions, and that's why I think it's important that the tools do include some risk factors that can be modified, because that points you in directions towards interventions, linked interventions, such as it could just be the frequency of probation input. It could be links to drug and alcohol services. It could be for psychiatric patients. It could be something around also their psychosocial support in the community. Adding in extra treatments for adherence to medication. Also, comorbid drug and alcohol problems, we know, is very important. So there's a range of things. I mean, that has to be thought through, and the idea that somehow these tools are going to solve every problem, they're not. I mean, they, on the face of it, they help you identify and stratify risk, but they're not going to have automatically a linked intervention. That has to be worked through. It has to be thought through quite carefully, and the feasibility of that looked at, and how it will be implemented. But I think it's the first step towards something like a bit like the Framingham, where you've got a statin, because but it's not just a statin. The Framingham can be used as a way of talking about other lifestyle factors: diet, exercise, stress. So it's a sort of, it's not just one simple thing that can be done. It can be used as a way of thinking about other interventions as well.
Right. I mean, Faye, if you have a comment that you want to make, please unmute and jump in.
Okay, so I'll jump in. So I think Seena raises an important point, and something that I was happy to see in this paper was a discussion of cutoff points. It seems to me that this is an area in which we need better science about how to do the cutoff points. Obviously, the AUC analysis helps, but typically cutoffs are basically not just in 2 levels; they're usually 3, and now there's recommendations in the United States to have 5 levels. So you have a very high, a medium low, and a very low. And the way in which people do those cutoffs is usually to look at the distribution of their population and just make judgments as to what they think goes into each of those categories, which I think is a very imprecise way of doing that. And it also increases the potential harm that can come actually from the tool. And of course, it affects the performance, because that means that someone who is considered a high risk or a medium risk offender who basically has a negative, poor outcome, people will look at that and say it's a problem with the tool, but actually it's more often a problem with how cutoff points are done, or cutoffs are done, and the risk classification. So I really feel that this is an area where more research is actually needed to help us better decide how do you do the cutoffs. And, you know, also I just wanted to point out, in the US right now, or North America, as Seena says, you know, there's a recommendation from a policy group now that we need to actually come up with more develop normative cutoff points of what we would actually expect from the population based upon people's likelihood of recidivating, and using that as a way of integrating into the tools, as a way of basically saying, you know, if we have a 25-year-old who's had 2 prior arrests in the criminal justice system, the likelihood based upon, you know, normative rates of recidivism would be 30%, and therefore if the person ends up scoring lower, then we would put them in a lower category. So there's a discussion now and some of us are working on some methodologies right now of thinking about how you could develop those normative rates. But I think the whole area of cutoffs is really critical, and it's something that, you know, is missing from the literature. So I'd really like to get Seena and Achim's thoughts on cutoffs at points, and, you know, how to safeguard so that you're, you know, essentially making sure that the performance of the tool is quite well, but also that the integrity behind what the tool is predicting is maintained.
If you could mute, that would be terrific. Achim, do you have a comment? You'd have to unmute.
Yeah, so first of all, around the cutoffs, from a statistical perspective, first of all, the important thing is that you decide what the cutoffs are before you start looking at the data in much detail. Otherwise, you end up with a scenario of looking at the AUC, looking at the point that's the furthest away, and just picking that one, which will give you a great theoretical performance, but in practice won't work as well as that. From a non-statistical, so from a clinical or from a criminal justice system perspective, there the question is very different. And I think that's what it should be based on. It shouldn't be based on what does best statistically. It should be based on what is informative for clinicians or for probation officers and so on. And on top of the cutoffs, I think it's important to consider having absolute risks as well. Because as Faye pointed out, the AUC sort of covers all possible cutoffs, but that's not how it gets used in practice. All possible cutoffs aren't really relevant if you only have 3, 4, or maybe now 5 cutoffs to look at. So, but if you have an absolute score, there the AUC is what actually captures this. Does it give a higher score, a higher percentage of risk of reoffending, for example, to someone who does offend than to someone who doesn't offend? So I think the absolute score is some way around it. And that can also be used to be more flexible around it. If you have a population where everyone's high risk, that's not really very informative because you can't differentiate between those. But if you have an absolute score as well, then within the high risk group, you can start to see people who are, as you said, high risk or very high risk and so on, and have sort of spectrum.
Right, exactly. I mean, I think it's interesting that when you presented your data for AUC, for the scores were relatively low, right? Around 0.6, give or take. But I assume that if you put those individual scores into a risk model, that the AUC of the entire model would have to be higher than that. Is that correct? In other words,
so that's partly a statistical artifact. The more variables you add,
Yeah.
the better the tool will do, because it can just draw random lines through all the points you have and find a pattern. If you wanted to add all of the models together, you would need a huge sample size to be able to do that.
Right. And you would
the
have
risk that many people run is to add lots of little bits of variables to a model that is way beyond what they can statistically test.
And importantly, to what you mentioned when you spoke at the beginning, is that if you ask for the model to include more data than is practical for the people using the model to collect, then you're not going to be able to use the model. Isn't that what one
That's
of the...
right. So I think it should be done in sort of co-production with the people who are actually going to use it.
Yeah.
And as Seena pointed out, the important question isn't just can we predict, but does prediction actually improve outcomes? We're in the tricky situation of be it in criminal justice or in mental health, you have to do risk assessment. So our mantra has almost been, well, given that this is something we have to do, we might as well do it as well as we can, as effectively as we can, in a scalable, cheap, effective way. The next question then is, now that we know how to predict, does it actually improve outcomes? So our paper is around how to select the best risk prediction tool. The next question is, once you select the best risk prediction tool, does it actually, if you link it to interventions, to services, does it actually improve outcomes?
Yeah, on this note, I have a question for the experts in the panel, because my understanding, reading the paper and listening to the presentations, is that we have an issue, which is the quality of the tools, basically the how can we have something which is methodologically sound, robust, applicable to the population, the external validity. But at the same time, my understanding is that there's an urgent need to use this now. So because I'm not an expert in the field, could you give us a few examples about how this can be used now? You finished the paper saying we provided a 10-point checklist that could be used and applied by clinicians, researchers, policymakers, I think regulators, HTA bodies. Can you give us a couple of examples about how to use it practically now?
Well, I think one example is, as has been noted in the United States, a lot of, probation agencies, a lot of judicial organizations, courts, and prisons are using risk and needs assessments. And I think that the 10 points could actually be something that they could ask their researchers for clarification on, so that they can sort of, learn more about the methods, and then also, how well the instrument, performs with their population. And that's kind of missing right now, is that, we have a scenario, in the US where you have almost 3,200 different probation agencies, each which might have their own validation going on for an instrument. And they're not really sure what to ask the researchers for in terms of knowing that, they're going to get the best product possible. For example, we're working with a probation agency that is going to be using one of the standard assessment tools. Our study is different from the risk and needs assessment, and that organization is just implementing the tool as the research organization gave it to them, without any validation being done prior to that. It's probably likely to have a lot of problems in terms of the tool being well accepted by staff, as well as in terms of the tool, working well with their organization without some checks and calibration, as has been noted. So I don't know if that helps clarify, but these are typical sort of scenarios that occur in organizations. I just did a review for Australia where they had a static risk tool that had never been validated even. They were just given a instrument that was modified off of an instrument in the UK, and they had been using it, and they were getting a lot of the instrument actually wasn't helping them because most of the clients were being placed into a low risk category, and therefore they weren't doing much in terms of providing services, but yet they had high recidivism rates. So I think the paper helps to give people almost a checklist of these are the types of questions you should be talking with your researcher about. These are the types of things that practitioner organizations should expect. And my colleague Alex Brino and I just wrote an article about the need for a national commission in the United States to review risk and needs assessments so that we establish performance standards, for development of the tool, but also then give user agencies an opportunity to essentially have a review process before they take on an instrument, particularly given to the fact that, most instruments are not checked for any type of disparate treatment that might occur from minority groups or gender groups or age distributions. And this is where the sort of harmful effects can actually occur.
Faye, okay. So that's very interesting. I mean, I think from a clinical perspective, it would be, clinical governance committees, guideline committees can also think about what they want to recommend. I mean, what's tended to happen is that people have sort of taken, the number of papers about a particular instrument as a sort of marker of quality, but I don't think, obviously, that's not good enough. And it might help just people to sort of think differently about some of the quality issues. And I think a lot of this these issues have been raised in statistical literature, prognostic research literature, so they may not be so easily accessible to some clinical services. So in that sense, I think it's quite useful to sort of lift it and try and summarize it and translate it for the audience of mental health and criminal justice. So I mean, I don't think it'd have an immediate effect, but it might start feeding into decisions people make, either at sort of local services level or higher levels, where there's a lot of I suspect guesswork going into how these decisions are being made.
Andrea, did you want to? Oh, Faye, you had something to say. Faye, please.
So I was just going to respond to Seena. So I think that I think there's a lot of blind faith that occurs in the world, and that blind faith is a practitioner organization has a research organization or a researcher, or they hire one of the companies that has proprietary tools, and they just follow whatever is recommended. I think that what this paper for me does, and I can, reference it within the world I work in, is to basically help people say, so what are some of the things that you need to be asking your researcher to do and to provide back to you? Because, there's so much in the US right now, almost every one of our reform initiative says use a risk assessment tool, right? And we even have foundations that have developed risk assessment tools for different parts of the system, but there's no papers out there on a lot of these tools that talk about how they were constructed. They don't talk about validation. I think the areas that are discussed in this paper about calibration and discriminant analysis are underreported here in the US. And so therefore, you know, when I saw the paper, I was extremely enthused because I think, you know, Seena and Achim have really kind of summarized in a way that could be very useful. And I really feel that the credibility of the whole risk assessment model in CJ may be on the line. And there's so many examples of newspaper articles lately in the US where misuse has occurred. And my most favorite one is recently a person was denied parole based upon a risk assessment tool that did not have anything to do with his performance during the 20 years he was in prison. It all had to do with behavior that occurred when he was 16 and 17 years old, right? But he had been incarcerated for 20 years, and the whole risk assessment was based upon actions he did on the outside when he was 16 and 17, and nothing about what happened or where he was now. And yet he was denied parole. And I think, you know, that's an example of where, you know, this organization picked an instrument, but the instrument wasn't designed for that setting or that decision-making process. And this is the kind of harmful effects that can actually occur.
Seena, I think that points to what you said about the actual performance of the tool in predicting future behavior. It has to have an impact on outcome, not just on prediction. Is that correct?
That's right. Yeah, that's right. And I mean, in the example that Faye gave, you know, I would have thought age is a really powerful factor. And what's interesting is a lot of the older tools, because they're underpowered, they use age bands, you know, like sort of 5 or 10 years. And to me, that's a sort of marker that it's not really a fit for purpose tool, because we know age really should be much more calendar year. It's such an important risk factor for so many different outcomes in life that, you know, that using 5-year or 10-year bands is a marker that, you know, your original sample was really small and you were stuck.
Right. Stuck doing that rather than using a continuous variable.
Exactly, using a continuous variable with obviously.
Right. We're about to run out of time in this hour. Andrea, did you have a comment you wanted to make about the generalization of these sort of risk models to use across mental health? This is obviously focused on criminal justice and violence prediction in that setting, and in forensic mental health and mental health settings. But did you have a comment you wanted to make about the use of what Seena and Achim have written about in terms of the development of risk prediction models for use across psychiatry or in other areas of mental health?
Yeah, I think it's a challenging thing for the whole mental health and psychiatry, having this kind of approach, which is methodologically very rigorous, but at the same time focusing on the implications and in the outcome. I think it's very interesting. I also like the thing that this article is for everybody. So it's not just the policy agency, it's for the clinicians, and locally we should establish committees that should employ this kind of approach rather than simply leave it for research. It has to be embedded into our daily clinical life, I think.
I totally agree. Seena, do you want to make a final comment before we wrap up?
No, I just I think, well, thank you everyone for listening. I think, you know, risk assessment has a role in mental health and obviously in criminal justice. And I think it's really just the important message, I suppose, is just take a step back before you select something, or you jump into something, or someone tells you to use something. Just take a step back and have a think about some of these issues, and how it's been derived, how it's been validated, how it's been reported. So if there's a sort of one take-home message, it's really about that. It's having the time and some of the toolbox really to be able to take a step back and evaluate these things for yourselves.
Perfect. Well, our hour has come to a close more quickly than I anticipated. Again, during our Hangouts, we could continue to discuss things, but this hour needs to close. I want to thank Seena, Fazel, Achim Wolf, Faye Taxman from George Mason University, and of course Andrea Cipriani from Oxford for joining us today. I'd like to thank behind the scenes Veronica Heaney for doing a terrific job getting us going in spite of the technical difficulties that we've had. Again, you can watch this video. It will be archived on our YouTube channel. Please follow our Twitter feed, and we look forward to seeing you for our future Hangouts. I'm Michael Ostacher at Stanford University. Thanks for joining us.